Thank you so much for inviting myself and Nicole to come and talk to you today about measuring nasal nitric oxide in children, and for that very nice introduction to us both. So what we're going to cover in this session today, firstly, as part of the task force for developing a practice standard for measuring nitric oxide, we first performed a global survey of what actually was happening in the world, to understand how people were measuring, or if they were measuring, nitric oxide in children. And Nicole's going to explain the outcomes of that survey to us, and that very much underpinned our need for standardization of practice. There was already a standard that was in use for sites in the United States for measuring nitric oxide, and it's a very, very good standard produced by Adam Shapiro. And we certainly didn't want to replicate that at all, but it only concentrated on children over the age of 5 who could do exhaled against resistance, and it concentrated on chemiluminescence analyzers, in particular the ecomedics, which is what they were using there. And our survey showed that that actually all we need to be screening younger children as well, and also the electrochemical as well as chemiluminescence analyzers are in use, and we therefore saw the need for a new standard for diagnosing in these patients. So what we're going to produce today are what technical considerations you need to make when taking the measurements, how to assess and prepare the child, the protocols for using different methods, because there are different methods in different aged children, and then how you should be reporting and interpreting results. And this is all to ensure that we get standardization, so that wherever you are in the world, whatever your practice size, or that you're doing it the same as people in other centres around the world, so that we can compare our results, and if we publish results, then we can amalgamate them as well. Can I have the next slide? So before we go on to actually measuring nitric oxide, it's really important that we know who to test. The standards themselves don't concentrate on this. It's purely about measuring, but it is important for you to know who should be testing. And there is no trigger to all these people should be tested, but any combination of symptoms such as neonatal respiratory distress, persistent wet cough from early infancy, persistent rhinitis, hearing problems, a combination of those factors should alert you to the fact that this might be PCD and that you should be investigating the patients. Also remember that 50% of people have situs anomalies, but that also means that 50% don't. So don't ignore people who have their heart in the right, in the correct normal positioning, because they may have PCD too. There are a couple of tools that have been published. One is PCD, which Laura Behan was the first author on, and the other was one by McGee Lee, both of which are tools that can give you a percentage chance that your patient has PCD based on their clinical history, and therefore give you an idea about whether you should go ahead and do further testing. The next slide. So nasal nitric oxide is one of the tests that we do for PCD. It's been known for over 20 years now that patients with PCD tend to have very low levels. And what you can see in the lower of these two graphs is results in patients referred to my centre some time ago now. It was published in 2015, but on the left, patients who turned out not to have PCD, and on the right, patients who had PCD. And what you can see is that most of those with PCD had very low levels. But it's important to note that there is some overlap. So nitric oxide is not a diagnostic test. There's an overlap in patients, but they tend to have very low levels. It's a very good indicator that we should go ahead and do further testing. That's why we have produced this practice standard. Next slide, please. I mentioned some of the symptoms that are typical, and it's really important that we don't do wide mass screening using nitric oxide. I don't want to go into the statistics of this, but those of you who are epidemiologically or statistically minded will know that if you do mass screening, you're much more likely to get false positive results. So if you have a low nasal nitric oxide level in a PCD centre where patients have been referred, they've been screened, then they've got approximately, certainly in my centre, it's about 10% of people that have a typical history turn out to have PCD. Whereas if you were to go to a bronchiectasis clinic and measure everyone with bronchiectasis, whatever their history, you'd probably end up with about, I think it's about 3%, less than 3%. And as you go through the different levels of certainty, the positive predictive factor gets lower and lower. Next slide. So it's important before we go any further to remember that nasal nitric oxide is not a diagnostic test. It's a very helpful test. So if nasal nitric oxide levels are low, you need to think of going on to do further investigations, which we're not going to consider further in this session today. But those tests might include genetic testing, high-speed video analysis, electron microscopy, or immunofluorescence testing. Next slide. And over to you, Nicole.
Yeah, thank you. So hello everyone, and I'm very happy to be here too. So the first part of my talk is about this survey Jane talked about, and I'm just going to give you an overview of the main results, and because it helped us a lot to develop the technical standards. So we decided to perform a survey, and BEAT-PCD members were really helpful in this task, because we were able to try to reach for every people actually measuring nasal nitric oxide and answering our results. So we tried to disseminate the survey all around the world, and we succeed in having more than 100 persons that visit the survey, but then we only kept people who personally measured nasal nitric oxide, which resulted in 78 people, but many people for same center answers. So we end up with 65 centers. But as you can see, we were very happy to have, well, Europeans, of course, because it was from the European group, but we are very happy to have many people from North America, from the North Consortium of North America, a few people from Central and South America, Australia, Tunisia, Palestine, and well, Europe for the rest. So it was a very interesting survey, and so I'll give you some result for this. First, the number of tests performed per year from the centers that answer the survey. You can see that very few centers, 20%, test few patients, less than 10 per year. So most of the people answering the survey were actually measuring regularly natural nitric oxide. And what was very interesting is that in most of the centers, there were few people involved in the measuring, less than 4. But in some centers, the number of people measuring nasal nitric oxide could be very high. And curiously, there was no relationship between the number of tests performed per year and the number of people involved. You could think that when there's a lot of tests performed per year, there's many people doing it. It was absolutely not the case. So in some centers, there was very few tests performed and a large number of people able to do it. So it came to the problem of how do you train people? How can you train so many people? How can you entertain their specificity? And the answer to the question do you have a standardized training for people? The answer was quite disappointed, because only 40% of the centers answered yes. They had a standardized training, and 13% an informal training, but it means that nearly half of the people measuring nasal nitric oxide do not receive standardized training. The next thing was whether children were tested in the center that answered, because we were targeted on measurement in children. And as you can see, nearly all the centers measured children, and most of them children and adults. And then the question of at what age do you start measuring children is very interesting, because you see that for the 61 centers who measured children, the majority of them start before 5 years of age, despite the only current technical standard, the ERS technical standard of Adam Shapiro, recommended to begin at 5 years of age. So despite this, a majority of people started measuring children younger than 5 years of age. Then the machine, you can see that the electrochemical device was available in 48% of the centers, and with a chemiluminescence device in 15% of the centers, which means that in our survey, the vast majority of centers owned an electrochemical device, and the chemiluminescence was not the majority. And of course, all the North American centers had only chemiluminescence, because it is their local standard. And there was kind of a relationship between the number of tests per year and having or not a chemiluminescence device. And we have seen that people measuring more than 25 children per year had more frequently chemiluminescence device, and children performing measurement under 1 year of age also had more frequently chemiluminescence device. When we ask for the method used, and we'll see in the details after in this talk, the different method used to measure nitric oxide nasal, but you probably have already heard of them. You can see that tidal breathing was absolutely similarly used than expiration against resistance, meaning that 15 centers measured only tidal breathing or only expiration against resistance, and 25 measured both. Then few centers used the other methods, but in the technical standard of the ATS, it's only the expiration against resistance which is considered and recommended. And despite this, you can see that tidal breathing was equally used. And there again, there was some kind of relationship between the number of measurements performed and the machine you have. In brief, people with chemiluminescence device were prone to sample both nostril and to sample more than once, at least twice each nostril, compared to people having only electrochemical device. So the reporting of the result in the survey, people say that they had a standardized report in 68% of case. And in this report, less than half reported the sampling flow, less than half reported the ambient NO, despite most of them measured it. And when we turn to the unit used to give the result, it was quite different according to centers. There were a number of centers using only ppb unit, and it was mostly centers using electrochemical device. Other using the flow of the output of NO, nanoliter per minute, and it was those having only chemiluminescence device, and some centers give both unit result using both units. And then when you ask for the threshold that people were using to interpret the result, I'm not showing you all the result because it was very, very scattered, and except for the 15 North American centers who have the recommendation to use 77 nanoliter per minute, other centers use very different cutoffs, so meaning that recommendations are probably important to uniform this. So in conclusion, this survey showed that Electrochemical devices were very, very widely available. Half of the center did not deliver formal training to staff involved in the measurement. Most of the centers testing children started measuring very young children before 5 years of age. Tidal breathing method was as frequently used as expression against resistance method, despite the lack of standardization. And nasal nitric oxide results were very differently reported according to technique, method, etc., and of course the absence of recommendation. So the next part is about the analyzers, the machine you can use to measure nitric oxide. So you may know that there are two kinds of devices. You got the chemiluminescence and the electrochemical. The chemiluminescence device has some advantages, but the electrochemical device also. So first, we'll see the advantages of the chemiluminescence device. This device is more accurate. It has a much higher precision than the electrochemical device, which can be important when we are measuring very low values of nitric oxide. And the precision of the electrochemical device decrease with the increase of the concentration of nitric oxide. So it's not fixed. It's not 5 ppb. It can be more than 5 ppb when the concentration of the measured is higher than 50 ppb. So a better accuracy and precision for the chemiluminescence. Then the measurement is completely different because the chemiluminescence device will instantaneously determine the concentration of the NO in the air that is sampled. So you have a continuous, instantaneous display of the NO you are measuring. The machine is sampling, and it allows you to see while you are performing the measurement, the quality of the measurement, and then to select on this curve the outcome you would like to report. In opposite, the electrochemical device just sample air in a chamber, and then after the cessation of the measurement, the concentration of nitric oxide is measured, but you don't have a real-time display of the curve, so you cannot really select which part of the blow or the sampling you want to record, and you don't have any idea about bad quality measurement. And then for the validation of the cutoff, the chemiluminescence has been validated for the cutoff of 77 nanoliters per meters using expression against resistance using a multi-center study. No such study exists for electrochemical device. But the chemiluminescence device is an expensive machine, and it's quite expensive to maintain, and it has to be calibrated daily for the flow, roughly around monthly for the nitric oxide gas, which is an expensive gas, and it requires quite a lot of training for the staff to use this machine. And of course, it's big and it's difficult to transport. And it's the opposite with the electrochemical, which is cost effective. It doesn't require any calibration. It may seem to be more simple to use. I mean, just to record to sample the child, but then it's not, since you have much less information compared to the chemiluminescence device. I don't know if it's simpler to interpret the result after this, but it requires less training, and it's totally portable. So you can, well, have one device for many departments or to test children in different location of your center. This is just to show you what will happen when you have an electrochemical or chemiluminescence device. On the left part of the graph, in the blue square, show you the beginning of a tidal breathing recording, which you can record with a child using an electrochemical device, and then the device will calculate the mean concentration of this first 30 seconds or 40 seconds. It depends on the device, and you can see that it's quite a low concentration of 19 nanoliter per minute. But you see that the technician did not stop the measurement there, because she saw that there were some kind of peaks that were high, and so maybe she just changed the orientation of the olive in the nose, I don't know. But then on the second part of these traces, you can see peaks much higher, and if you can measure the peaks and make the mean of the peaks, you can see that the result will be much higher than 19, because it's 69 nanoliters per minute. So this is only possible if you got chemiluminescence device. And another part of the difference between the two devices is that when you're using an electrochemical device and you are measuring NO during exposure against resistance, you just set up a duration, and if the child is not able to blow out the 10 seconds you have asked the machine to sample the device, you will have no result or a low result. And with chemiluminescence, you can make the child train himself or herself by looking at the plateau and encouraging him or her to have a longer plateau, and then in the end you succeed to have a plateau, as you can see on the right part of the graph, which is something you cannot do with chemiluminescence, with electrochemical, because it would have stopped much earlier and you wouldn't have any result. The other point is the transnasal airflow rate, which means at which airflow the machine will sample the air in the nose. It is very important to know which is the airflow, the sampling airflow of your machine, and it's important to check it and to report it. Why? Because if you want to calculate the NO output, the nasal NO output, you have to multiply the concentration that the machine will give you in ppb by this sampling flow in liter per minute, and it will give you the NO output in nanoliter per minute. So you have to know it. And it was considered that it should be between 0.25 to 3 liters per minute, but in fact, it has been shown that it is absolutely different result of NO output according to this sampling flow. And it is known that very low transnasal flow, such as 0.12 liter per minute, give less specific and repeatable measurement compared to 0.3 liter per minute, so it shouldn't be used. And higher transnasal flow, such as 1 liter per minute, which is a flow very usually used in adults, is not well tolerated in young children because it's too high. And so they just will stop the measurement and you will not get any result. So in children, it is recommended to use a flow close to 0.3 liter per minute. And it is important to report it, so you can compare your result with the literature or with someone of another center sending you a result from a child you are seeing in your center. The ambient NO is quite complicated to know exactly what to do. What is certain is that ambient NO, since we sample nostril in series, the ambient air going into one nostril and the machine sampling from the other nostril, it is certain that the ambient NO will increase the nasal nitric oxide result. The problem is to determine how much. It is quite nearly impossible to do, but in a large study, Struben had demonstrated that it was around 50% of the ambient NO, which will be measured in the other nostril. In another study, it was 20 to 24% of the final result, but well, we don't know for sure. So we recommend that if the ambient NO is high or higher than 20 ppb, you have to deduct it, to subtract it from the result, and then to see where is your value. If your value is near or under the cutoff, you have to measure again the child on a day when the ambient NO is not high. And for example, if in this example the ambient NO is 49 ppb and the measured nasal NO is 281 ppb, so if you just measure the output by multiplying 281 by the airflow sampling, 0.33 liter per minute, you got 93 as a result. And if you correct with the ambient NO, you will have 76 nanoliters per minute, which is the threshold. So you may need to control this child on another day. And for example, we say in the recommendation that under 20 ppb, you may not adjust for the ambient NO. Just remember that 20 ppb is equal to 7 nanoliters per minute. So when you got your result without correction, just subtract 7 nanoliters per minute, and you will see that at the error you could make if the NO is lower than 20 ppb. But if the NO is higher than 20 ppb, it will be higher than 7 nanoliters per minute, so it could be something important. For example, in this child, in the same child, you can see the breath hold from the right nostril and 2 breath hold from the left nostril, but you see the ambient NO can be seen, and it's very high. So when you do the measurement for all these traces, and you're looking just at the highest one, which is the right nostril, you can see that you go from nearly the threshold of 75 nanoliters per minute to 35 nanoliters per minute when you take off the ambient NO. So it's a very difficult result to interpret, and you may ask the child to come back. And it is the same, it's the same child. When you do the tidal breathing method, you can't have a reliable result. You don't know exactly how it would be if the ambient NO was low. The material, you have to need to have olives, the size adapted to the size of the child's nostril, and it can be even plastic or foam. You have to have filters for humidity and debris not to come into the machine, but also for the microbes, and we all know this now. And it can be a single filter or filter in series. And then if you want to do expression against the resistance, you have to get the resistance, which can be included in the handle of the machine, or you can have an external resistance, such as cardboard with a, as you can see, or party favor tapped close at the distal end.
Great, thank you, Nicole. I'll take over for you to have a breather now for a few minutes, and we're going to talk about assessing the child. And as we've already said, the Shapiro standards that the from the North American consortium that they use was for children over the age of 5, and they therefore were recommending using the exhaled against resistance method, and that's what we also suggest in our standards, is that for compliant children that are able to follow instruction, that you should be using exhaled against resistance, which Nicole has already explained to you. And but the other method that can be used, and in some children aren't able to understand the concept of exhaling against resistance, and so doing a breath hold maneuver might work in those children. So it's, when you're working with children, it's really about understanding their capabilities, their understanding, and using the technique that gets the most reliable result for that child. Next slide. So, but a really important part of our study, as Nicole said, people were already measuring levels of nitric oxide in children less than 5 years of age using tidal breathing. It had sort of seeped into normal practice, but there was no standardization for it. And as I'm sure are all behind, we want to be diagnosing PCD in young children. The younger, the better. And so we need to consider at what age can we reliably start using nasal nitric oxide as one of the diagnostic tests for PCD. Remembering that some other tests can definitely be used from birth. But what about nasal nitric oxide? Well, June Marthin, there's another paper by Adams et al., but June Marthin did a very nice longitudinal study making longitudinal measurements of nasal nitric oxide in healthy infants from birth right up to the age of 22 months. And what she showed was that the level of nasal nitric oxide in very young children, so under 6 months of age or even under 12 months of age, was low and often within the same range as we consider not diagnostic, but suggesting that the patient might have PCD. So you can get very low levels in children under the age of a year. What she also found in her study was that their levels just continued going up through those first 24 months, and we reckon that by five years of age, although the levels still might be going up a little bit, we can use similar cutoff values by the time you get to about 5 as you use in adults. So that's 77 nanoliters per minute that Nicole was mentioning. Other points that are really important from June Marthin's study was that she, as well as taking the routine measurements at set times through the study, she asked people to contact her if their child had an infection, and she took measurements then as well. And what she found was that I've circled it here, that actually children had low levels of nitric oxide, lower than they normally did whenever they had an upper respiratory tract infection. And often those levels were within the same boundaries as patients with PCD might have. So they were below the cutoff. So what the task force considered this study meant for us when considering standardization was that it's probably not reliable to be taking measurements of nitric oxide in children less than 12 months of age, because they have levels that are low and might not be discriminatory from PCD, but also that we should avoid taking nasal nitric oxide measurements in children who have viral or other infections, because their levels again might be falsely low. So in those patients, it's just a matter of waiting until they've recovered from their infection by a few weeks. Next slide. So then we need to discover what's the right maneuver for the child, and really this just entails having a good technician, nurse, physiologist, whoever's going to be taking the measurements in your study, who can work with the child to decide which is the best test. So it might be tidal breathing, so where they just breathe normally, and you can see on the left-hand picture a very young infant who is asleep in her mother's arms and is just breathing normally. In the middle picture, there's a child of about 3 or 4 years of age, who again I suspect is using tidal breathing, although she's wide awake. She's just being reassured to be breathing normally. Whereas the child on the right, what you can see in his mouth, he's holding a party favor. He can blow that out, creating a bit of resistance to close his velum, and the measurement is being taken during that maneuver. So, and if one of these techniques doesn't work, then try one of the others. And if you get a low level when using exhaled against resistance or breath hold, You can also check that the level is genuinely low by using by taking tidal breathing measurements. Next slide. So then it comes on to preparing the child. We need to check the equipment and calibrate if it hasn't already been done that morning. And we'll come on to that again a bit more later on. But then you need to assess the child to determine, actually before they even get to sitting in the chair with the nitric oxide, as I mentioned, you need to determine the likelihood that they've got PCD. We don't want to be doing tests on every child that's got respiratory symptoms. You want to decide what's going to be the best breathing method and olive size, depending on the age of the child. And we want to determine whether there's any nasal obstruction. And many of the children that we're testing are going to have nasal obstruction. And it might be that you, particularly in slightly older children, that you can ask them to blow their nose or even to use nasal douching to prevent obstruction influencing the result. You then need to explain the procedure and, if possible, if they're old enough, practice with the child. So whilst they're not actually connected up to the machine, you can get them to play with the olive, get used to it and explain what's going to happen. You can get them to practice holding their breath or doing exhaled against resistance. We then attach the flow sampling line to the olive with the attached filter and put the olive in the nostril with no leak, making sure that the other nostril is left open to the air. The other nostril shouldn't be closed. And what our standards are that we should obtain 2 nasal nitric oxide measurements from the first nostril and then 2 in a second nostril. And in the first nostril, we're looking for repeatability between the measures to show that we've got a repeatable test. If we're using exhaled against resistance or breath hold, it should ideally be within 10% within the nostril, and for tidal breathing within 20%. And between nostrils, we're talking of 10% for exhaled against resistance and breath hold, and 30% for tidal breathing. Next slide. To mention that, so we're giving you a talk today. The best way to do it is actually to get hands-on training. And as Nicole said, less than half of people doing the measurements when we did the survey had actually been trained. The best way is to learn from someone that's experienced of doing it, but also attached to our manuscript. If you go to the ERJ website where the manuscript is freely available, if you go to the figures and data section and then scroll right to the bottom of that section, you'll find some videos that have been done by Nicole, Amanda from my group, and from Stephanie Davis in America. They include looking at calibration of the device and then the various maneuvers that can be conducted in the children. So I'd really recommend looking at those videos. Next slide.
Yeah, thank you, Jane. And yes, really, I think it's the best thing to look at the video. That's also what I've written on my part about the standard operating procedure, because it's very easy to look at it and to understand from this. So I'm going to go fast for this part because Jane said a lot of it. And then, so I will not explain again that the child must be seated, etc., and the olive put in the nose, etc. So this is very important, that the other nostril should be unobstructed for sampling the air from one nostril, and yeah, it's going on in the other nostril. Just coming back to the repeatability, just to answer how do we get to the 10%, 20%, and 30%? It's just we made a retrospective study on a large panel of results from my center that were released, and we saw that around 70% of measurement were within 10% for expulsion against resistance and breath hold between the 2 nostrils, and also in the same nostril. It was around 70% of reproducibility was less than 10%. And in opposite for tidal breathing, which is a much variable method because the child is breathing over the flow slump, the slumping flow, so it changes the NO concentration continuously. When we look at this proportion of reproducibility, it was 30% between the two nostrils and 20% for the same nostril. That's how we end up with the 10%, 20% and 30%. So that's what Jane just told you. We are looking for 10% repeatability in the same nostril for method with the velum closed, which is expression against resistance and breath hold, and 20% for tidal breathing. And when we are performing measurement in both nostrils, we are looking for 10% reproducibility between the nostril for the velum closed method and 30% for the other. You have to wait a little bit between measurement, and the child will tell you that he needs to just calm down and then rest and then start again the measurement. You will see this, and then we will see how to report the result. So when reporting the result, which Jane will explain to you, you will be able to grade the reliability of your measurement according to this internostril and intranostril repeatability and the kind of device you're using. The chemiluminescence analyzer are most reliable than electrochemical because they are the precision is higher and you can see the trace and you can select the outcome, so it's more precise. And also according to the method used, the expertion against resistance and breath hold method are more reliable than the tidal breathing method. So according to the device you're using, the method you're using and the viability, you would grade the reliability of your result between A and F. And it doesn't have any relationship with the interpretation, the final interpretation you will have, but it's on the reliability of your measurement. So for the maneuvers themselves, for the expertion against resistance, the child will breathe in deeply, not, well, total capacity is not measured, so you don't need to say that, but deeply inhale, then to be able to exhale long enough against a resistance that will develop the hyperpression in the pharynx and close the velum against the crines. So until you have the plateau of at least 3 seconds, which you can see on the chemiluminescence device, you will stop the measurement after this. For the electrochemical device, you don't have the curve, so you set a time, usually more than 10 seconds, and the child has to blow until the end of this time you have set 10 seconds or more, I don't know. And then you usually cannot really select the part of the sampling you would like to see as a result. And for the breath hold, the child will also deeply inhale near to total lung capacity. And what is important is that you have to ask the child to close the glottis to perform this hyperpression in the pharynx, so the velum will be closed. So this is not very easy, and some child don't get it, and some other will get it very easily. So it's difficult. It's quite unpredictable which child will be able to do it properly. If the child just breath hold without closing the glottis, then the air sample will be diluted by the air coming from the lower airway, which has low level of nitric oxide. So the final result will be lower than when the velum is closed. If you don't have a CO2 capture by the other nostril to check for the zero for the real apnea, which is generally the case, you don't have it. It's very difficult to detect this, especially when you have an electrochemical device. I will show you an example. So you see the child performing expertion against resistance. He has an incentive, and you're going to speak French by the end of the talk, and the plateau detected. There's one letter missing, but when when the child sees the green face, he knows that he's in the good range of flow, and then the measure can stop, and the investigator can look at the NO traces while the measurement is performed, and afterward to select the plateau. When the child is breath holding, he doesn't have any incentive except from the chemiluminescence device that the curve is going up, and you can encourage the child to continue to breath hold because the curve is still going up, and when the curve is plateauing, you can say to him or her, well, it's good, continue, it's a good plateau, and then stop whenever you want and select. You're going to say that the plateau is very wide, but the value are very low, so it's a few less than 1 ppb difference. And from the difference again between expression against resistance and electrochemical is that if you're using an external resistance, like I'm showing you with this with child, if you're using an electrochemical device again, and the child cannot blow out for the 10 seconds, either the measurement will stop or the measurement will sampling ambient air after the child has stopped blowing in the party favor, and so in that case you will have a very low result. It's only with the chemiluminescence device that you will be able to stop whenever you want the measurement and select the plateau, which is very early in the blow of this child, because he couldn't sustain blowing against a resistance, and you have a result which is very high and normal, whereas with the electrochemical you will have either no result or a low result, because it would be the mean of the 10 seconds. Then again, if you're looking at these traces, which are traces performed during expression against resistance, you can see that we have selected plateaus. The plateau are it's written very small at the bottom left of the graph. The duration is 3 seconds. The variation is 5.5% for the top one, and the mean is in ppb 121, and I put it upstairs. But you can see that both left side measurement are quite reproducible, 42 and 44 newton-liter per minute. And then you can say, well, it's slow, I can try another method with this child. It's the same child, and the breath hold, the first measurement is not good because the plateau is too variable, because the difference between the minimum and the maximum is 14%, while we accept less than 10% difference between mean and max to say that it is a plateau. So the first one is not very good because of this, but the second one is quite good with the plateau. And with a real plateau with 7% between minimum and maximum, and a 3-second plateau. And you can see that the result is 47 nanoliters per minute. So it's quite similar to the expression against resistance, which is expected, because once the volume is closed, whether it is by blowing into a resistance or by performing an hyperpression during an apnea, doesn't matter. The result must be the same. So if you are performing both technique in a child, it should be the same results. In this child, for example, you can see on the right side that the plateau is still going up when the child just ends blowing. And this is something you can see with the chemiluminescence device. And well, the result is high, but it means that it might be higher. And in this same child, we have tried to do the breath hold, and you can see that the plateau took much more than the 10 seconds of blow the child was performing in the upper graph with during the expression against resistance. But when you could wait for nearly 20 seconds, because the child was breath holding very, very good, the result is much higher with breath hold compared to the expression against resistance. And the variability between the nostril was higher using the expression against resistance because the technique was not good, the plateau was not achieved, while it was very low, 3%, when the child breath hold. So normally the result should be the same, but here in this child, if you had only electrochemical with this kind of result, with expression against resistance lower than breath hold, you could conclude that there is a technical problem with at least expression against resistance because it is not usual. And this is what we were talking about, the breath hold difficulty for some children. This child was breath holding and I was sampling, so I was really there. And I couldn't see or detect that she was not correctly breath holding. And it's only when the measurement was finished that I could see that there was no plateau. But if I had an electrochemical device, I would have the mean result that you can see, 49 nanoliters per meter, and no curve, so I couldn't see the result. So I would have a low breath hold result in this child. So what should I do if I have electrochemical device and also chemiluminescence? I would try another method. And expiration against resistance was successful in this child, and she had a very high plateau of 243 nanoliters per meter. But imagine she was not able to perform this. What should I do with only breath hold showing a low result? Jane told you, when you have a low result with expiration against resistance or breath hold, you can try to do tidal breathing and see what's going on. And in this child, it's the same child, the tidal breathing would show you that the peaks, the mean of peaks, if you got chemiluminescence, are high, 142 nanoliters per meter. And if you got electrochemical device, you will have only the mean of 30 seconds, and it's the lower result in red I've shown you. It will be 90 nanoliters per minute. It also will be higher than the breath hold. So you could say confidently that there was trouble with the breath hold method because the result of the breath hold method was lower than the tidal breathing, and the tidal breathing method should at least it's lower, very rarely equal to a result obtained with breath hold or expression against resistance. That's why I think you should master the tidal breathing method, because you may need to check for all low result with tidal breathing. It's quite easy to perform. You just have to ask the child to breathe calmly with the olive in the nose, and then to select the peak with the two bars on the screen, and to record the maximum value of each peak, 3 to 5 peaks, regular peaks, not different by 20% or 10 ppb, whichever the greatest. And for the electrochemical device, you don't have the peaks, you just have the mean of a duration, generally 30 seconds or maybe less. You can probably set it, or it may depend on the machine, but it's not the peak. So the results you will obtain with electrochemical device is automatically lower than the one you will obtain measuring the peaks and using chemiluminescence device, as you can see in this example. Okay, so now a few traces. You can see on this first tracer that there is quite irregular peaks, but there are some of them that are reproducibly high. When you are losing chemiluminescence, you will have a result of 46 nanoliters per meters. While using electrochemical, you will only have the mean of the duration of the measurement, which is much lower, 24 nanoliters per meters. And you can have a look at the ambient NO, which is on the right part of the screen, and it's slow, it's at 5 ppb, so I don't have any inference from ambient NO. This was the right side, and the same channel is measured on the left side, and on the left side the peaks are much higher, and I have 3 reproducible peaks among not completely reproducible peak, which is high, with an output of 129 25 nanoliters per minute, while electrochemical result, which is a 30-second result, will be lower, will be 69 nanoliters per minute. And this is the same child, and you are performing a second measurement in the left nostril, because the right nostril is lower and has less permeable nostril. And again, you can see a result that is 129 nanoliters per minute or 66 nanoliters per minute using if you use electrochemical device. So in this case, you will have a high internostril viability and a good intranostril viability from the left nostril. I would like to mention crying, because that's something that may have been optimistic in the ATS standard, where they say that we could measure children while crying. I'm not sure. Crying first increase the peaks, then decrease them when the NO is depleted. And in this example, you will see, and it's written in French again, but you will learn French. It's written in French then that the child just stopped crying at 20 seconds. And you see its tidal breathing, the peaks going down from 400 to 200 as soon as the child stopped to cry. And then this same child, a crying child, he was just crying at 30 seconds and 55 seconds, and you can see that peaks are occurring at the same time. So I feel that crying is not a good time for measuring nasal nitric oxide. So if I do a summary about the measurement of nitric oxide, depending on the age of the child, after having checked for all that Jane told you about the symptoms, etc., and having checked for the ambient NO, you would measure the child using tidal breathing method if the child is under 5 years of age, and you will try a method with volume closed if the child is older. You can first try expression against resistance, and if it's a failure, you can try a breath hold, or if the result with expression against resistance is low, you can try breath hold method. If the one of these techniques is successful and the result is above the threshold, you will see after with Jane, you can stop measuring the child. But if the method are successful and the result is low, you can check with the tidal breathing method whether it is truly low. And then I will not go through the report, because it's now Jane that is going to explain this to you.
Thank you, Nicole. So we're getting towards the end, and I realise we've been talking for an hour already. So I'll try and hold in there, if you don't have to go. If you do, it is being recorded, so you can catch up on the end of the talk. But it's important, once we've been through all that careful measurement, that we then record actually what we've done and what the results are. And in the standards, we make recommendations about what should be recorded. And then again, when we go, it will enable us to compare our results with other people, because we'll know that they've been taken and recorded in exactly the same way. And we'll be able to contribute, for example, to collaborative research because of that. What we're suggesting you report are the analyzer model. So what type of machine you've got. The sampling rate, as Nicole said, is extremely important because it allows you to standardize the parts per billion into a measurement of nanoliters per minute. So that's extremely important to measure and record your sampling rate. Similarly, the ambient nitric oxide level is extremely important to measure, but also to record, so that you can make any adjustments and decide what the impact of ambient nitric oxide might be having on your measurement. You then need to record as raw data for each, the 2 measurements from your right nostril and the 2 repeatable measurements from your left nostril. And you then need to calculate the repeatability to ensure that those really are repeatable measurements that you can then take the average of for your final result. It's important to make a note of any technical problems or problems that the child had. For example, Nicole was talking about crying. It's important to make a record of those, so when you look back, you know how to interpret the results reliably. And then finally, you want to put the final result. So firstly, in parts per billion, you writing down the highest result from the highest nostril minus the ambient NO if it's high. And then a finalized standardized measurement that you need to calculate by multiplying the final result in parts per billion by the sampling rate that the analyzer was working at. In our standards, in the article published in European Respiratory Journal, you will find an example pro forma that you might like to use in your clinics to record all of that data and make sure that you have it all recorded in a standardized way. Next slide. But something that is coming very shortly, I believe, to people that have ecomedics. Ecomedics have actually designed, based on our standardization, a very nice Excel sheet that they will be allowing people who use ecomedics machines to use, in which you can input the results of those key factors, and any of the calculations that need to be done will then be calculated for you using the algorithms in the Excel sheet. So I think that's going to be a very useful spreadsheet that Nicole has been in conversation with ecomedics about, and I believe is becoming available as of today, so you can speak to your ecomedics representatives. Nicole will be able to confirm that afterwards. Next slide. And then the interpretation, all important. So we've got a result. How do we interpret it? What does it mean? Well, it's important to remember that there are false positive and false negative results. So not everybody with a low nasal nitric oxide level has PCD, and you therefore need to go on and do further diagnostic testing, such as genetics or high-speed video analysis. But similarly, not everybody with PCD has a low nasal nitric oxide level. So we know that there are some genes in particular that are associated with normal nitric oxide levels. So just bear that in mind when interpreting the result. We've already discussed ambient levels of nitric oxide, and it's important to consider whether to ask the patient to come back on another day if it's possibly impacting the results that you have. You need to repeat the test. I've already mentioned the ecomedics pro forma, but I think it's also important to say always check a low level on a second occasion. So if you have a low level, do check it again, as well as going ahead to do further investigations, or maybe ahead of going ahead to do further investigations. As I showed you from the Martin paper, that factors such as viral infections can cause low levels. Regarding cutoff levels for interpretation, we've very much followed the validated cutoff of 77 nanoliters per minute that was published by McGee Lee and is included in the North American technical standards, and that's applicable as long as the sampling rate is around the 0.3 liters per minute rate. If it's lower than 77 nanoliters per minute, do check with tidal breathing to exclude the false positive result, and Nicole's shown you some nice traces to demonstrate that. And as I've already said, as a further diagnostic testing is also indicated. Cut-off levels for tidal breathing, and this is mostly going to involve younger children, and it's just important to say that reference data is very limited, but in the experience of the task force experts, at the moment we would say not to be using it as a diagnostic test in those younger than 12 months. Between 1 and 2 years of age, a cutoff of 30 nanoliters per minute is probably reasonable, but we would recommend repeating the test again once they're older, if there's any doubts extending. And for children of 2 years and older, we up to the age of 5, we're suggesting a cutoff of 44 nanoliters per minute. Next slide. And remember that hands-on training is important. Nitric oxide doesn't confirm or refute a diagnosis, and you may need further diagnostic testing. And call the child back for a test on another day if the child has a respiratory tract infection, if the results are equivocal, if the child's very young, etc. Anything that puts the result into doubt, check it again in the future. We now have a few questions that we can go through, although I'm aware that we're probably exceeding our time limit, and it might be that you want to have questions before we go on to ask, give you a short quiz. What would you like us to do, Yinting?
Thank you very much, Jane, Nicole. That was an excellent summary of all your task force efforts. And actually, we do have a lot of questions. You actually partially replied most of them then in your next couple of slides, but I think we will still go through them. So let's kick off the Q&A with Rob's question. He asked, do you know what the normal ranges of nasal and OR when using different techniques? What is a low reading PCD plus using electrochemistry versus chemiluminescence with different techniques?
Thank you. Do you want me to answer that, or do you want to answer that, Nicole?
I think it corresponds to your last.
Okay, yeah, I'm happy to. So thanks, Rob. Good question, and I think we've at least partially answered it. But to clarify, that so we're really quite confident that in children over the age of 5, using a chemiluminescence and either breath hold or exhaled against resistance, as Nicole showed, they should, if you're technically doing the test correctly and you're confident in the results, then you should get the same results for both. So the cutoff is the same. They should be the same results. For tidal breathing, you're going to get contamination of the lower airway, but also the children are often younger children that you're doing the tests in. Because it's a test that we tend to do in children that are non-compliant, and I gave you the cutoffs that we're recommending for those, but we're less confident that those really are the cutoffs for those age groups. That was a consensus based on experience rather than a well-validated trial, and we need that data moving forwards. There's no electrochemical devices are less accurate than the chemiluminescence, but we would expect the cutoff still to be in a similar range, and so we've suggested using similar cutoffs if using the electrochemicals to the chemiluminescence. But again, there's really such limited data that we need further research to really accumulate the reference data for those. For all the different analyzers and different methods, but we've tried to simplify it, and I think we're confident that those results should be those cutoffs should be usable and probably fairly accurate. Does that answer the question?
Thank you, Jane. We now have a question from Myrona. I believe you've answered the majority of the questions since it was posted, but just to reiterate the key points. Thank you both for this excellent presentation. My question is coming more from a research perspective. If there is time after any clinical questions, you described all the different parameters that are important to accurately measure nasal nitric oxide. Since there are differences from centres to centre and even between measurements at the same centre, if we want to compare or pool measurements in a large collaborative study, which are the parameters we should always collect? In addition to the result and the unit, should we always ask about the machine, the ambient NO and the breathing manoeuvre? And Myrona has also said, to clarify about my question, I'm talking about parameters we need to be able to decide if a measurement is below the cutoff or not to compare exact values.
Yes, it's quite difficult for studies performed before we have published this technical standard, because people are not expected to follow all the technical standard, and we hope that this issue will disappear if people read and accept to perform the measurement the same way. One way, but I don't think people would retrospectively be able to give you, Myrona, would be to ask for the grade of the measurement, because the grade can give you an idea of the reliability of the measurement. But I think you at least should ask for the machine used. So you have the technique, is it electrochemical or chemiluminescence, because it will be much more precise and reliable when it's chemiluminescence. And you may look for the effect of machine on your results, for example, whether centers you merge were using electrochemical or chemiluminescent. You may look at this as a parameter to test. And for the ambient NO, it's you can at least, you know, in some places, for example, for me in Paris, I know that ambient NO can vary a lot. But in the Dutch study I mentioned, where the NO was changing by 20% or 24% the measurement, the ambient NO. There were 3 towns in the Netherlands, and one had always very low level of NO. So some centers may know at least whether they have a constantly low ambient NO, which is an important information, and some centers may acknowledge that they may have variable NO, but they don't measure it, so they cannot tell you the effect on their measurement, or they measured it, and if you can correct for the ambient NO, it's perfect. What else? What is in the question? It was machine, NO, and method, maybe. I don't know whether she asked for method use, whether it was expression against resistance. Usually it's quoted in the studies, how you measured it. And of course, it's not the same cutoff.
Great. Thanks a lot, Nicole. Myrona also says very helpful. Many thanks.
Thank you. You're welcome.
So the next question is from Stephanie. Thank you very much for this great talk. In a busy clinic, do you consider one measurement per nostril sufficient? If these show normal results, or even only one normal measurement for time-saving reasons?
I suspect Nicole will say the same as me, that I think that it's such an important diagnosis to make, and it's such an important measurement to take. I really understand the busy clinic concept, but I think if you're going to do a measurement, you really need to make sure that the measurement is taken in a standardized way. We therefore would recommend that you take the two measurements from each nostril.
Well, yeah, I don't know what it's, if the issue is really time, if it's expression against resistance or even tidal breathing, it's less than 1 minute. So it's time is really that
Yeah.
it's much quicker than to perform usual lung function testing. So
Yeah, I think the main time constraints are actually getting the patient into the room, explaining it to them, and getting them in the good position and so on. So once you've got the first measurement, it doesn't usually take so much longer to go on and do the further measurements.
yeah, I totally agree.
I think the issue that can be there if you're using an electrochemical is that you pay per test on certainly if you're using the Vero, and I think that's a different issue that actually you may end up having to spend more money, but even then, in comparison to the other diagnostic tests, it's not so expensive.
However, the time issue can come up when it's difficult to perform the maneuver for the child, and you spend many time achieving at least one expression against resistance or breath hold, but and it has taken you, I don't know, 15 minutes. You can't afford for another 15-minute trial. So this can be a way to answer that. Yes, time saving, but really time saving, not 1 minute.
In those cases, we tend to ask them to come back on a different day. When maybe practice at home with the Olive, get the parent to practice with the child handling it, because it's often just that they don't understand what's required of them.
So Suzanne says, thank you for this excellent and useful talk. We have a chemiluminescence machine, Ecomedics CLD88. When measuring an NO using tidal breathing, the measurement is always noted to be offline and the results given only in ppb, with no results for sampling flow rate. It's not a true offline measurement. The quirk is mentioned in the American guidelines, but I don't understand why this happens. Does anyone have an answer to this? Thank you.
Yeah, it's. Can I answer, Jim?
Yeah, please do.
It's just a question that it is not an offline measurement. It's just a conception of the ecomedics that is done to perform nasal nitric oxide measurement online with the program which is written nasal nitric oxide. And then if you perform, if you select this program, the machine will expect the child to breathe into the handle, as I showed you the young guy with the incentive, the smiley. So this is when it is the program nasal nitric oxide from ecomedics. But if you want to perform tidal breathing, of course, you cannot use it because the child is not going to blow against the resistance in the machine. So you select the offline machine. It just means that the machine is well, as when it's not running a specific program, it's just sampling and giving you the PPB, the NO PPB, and give you the trace. And it could be a real offline, which means you have collected in a bag and nasal nitric oxide for any sample, air sample, and connected to the sampling line. Or it can be that you are doing an online tidal breathing measurement, but it doesn't matter because the machine will not do anything with the measurement. It's you who are selecting the peaks and recording the peaks and selecting whatever you want. But the name offline it just means that it's not online. I mean, it's not the nasal nitric. It's not. You're not using the program, the nasal nitric oxide program from ecomedics. But it's obviously it's an online measurement.
Okay, thank you, Nicole. I understand that point. What I don't quite understand is that in all the other measurements that we do, if we use breath hold against resistance, for example, we automatically get in the printout or the readout the conversion to nanoliters per minute, and we get the flow rate. but we don't get any of those measurements when we do the tidal breathing. We just get the parts per billion. So I don't know, because the flow rate will vary, whether or not it is valid to use the standard flow rate, whatever that is. We don't know what it is when we're doing the tidal breathing. We don't get the starting flow rate.
You have to check for the flow rate. It's very easy on the screen, on the first screen. It's, I don't know if it's the same for your screen. There's somewhere, it's some kind of settings or parameter or something like that. And you just click on this and you have all the changing measurement, and you have at the bottom right, the current flow sampling, which can vary from one day to the other one. It's available.
Okay,
so,
that's really helpful.
yeah, because the offline software cannot know which part you have selected.
Yes,
So
okay.
it cannot give you the output.
Okay, that's great. Thank you very much.
You can email me and I can do a picture of my machine.
Great, thanks.
You can email me.
Good.
Or ask your distributor.
Yeah, we have, but we didn't get a satisfactory answer. I've been.
Okay. Send me an email and I'll do your picture of my.
Okay, that's lovely. Thank you. Thanks.
So I can't see any more questions in the chat, and in the interest of time, I'd just like to say a massive thank you to Nicole and Jane for the session today. And thank you to everyone for participating in the Q&A session.